In this lesson, we're going to talk about common respiratory drugs. We'll start off by talking about the modes of delivery of common respiratory drugs, and then we'll discuss the types of drugs used to treat common respiratory problems, including excessive secretions, infection, bronchoconstriction, and hypoxemia. There's basically two modes of delivery of respiratory medications, oral or injected, which would lead to a systemic distribution. But we can also use inhaled medications because the lungs are the only part of the body that are directly exposed to the outside environment. We can inhale certain drugs that are directed to the lungs. In general, the inhaled versions are going to have fewer systemic side effects. But if we have big problems with airflow, if we have airways that are clogged up or constricted, sometimes that inhaled medication will not get to those airways, and we'll have to use a systemic distribution. The most common modes of inhaled drugs are metered dose inhalers. So I think probably many of us are familiar with this. They're used frequently for asthma. There are videos online where they show you how to use this. If you have a patient who's using this, it's always a good idea to ask them how they use it, to have them show you, because many people use it wrong. The other major mode would be a nebulizer, and this is frequently used in the hospital by respiratory therapists to deliver respiratory medications. So there's a machine that basically creates a mist out of the medication, and that mist is inhaled over 10 or 20 minutes. So when we think about drugs used for pulmonary issues, there are a couple of kind of issues that we come across in pulmonary disease, and one is the management of secretions. So here we see kind of a cartoon of an airway, and here's a blob of mucus. That blob of mucus is going to kind of block that airway, and of course, if we're blocking the airway, we're not allowing air to get through. So that's a big problem. Normally, we have a cough that can help to clear that airway, but in many of these respiratory diseases, we either have excessive production of mucus, or we have an inability to clear that mucus for a variety of reasons. So there are a couple of categories of drugs that we can use to help manage secretions, and mucolytics are one category of drug that decrease the viscosity of these secretions to help make it easier to expectorate them, to cough them out. So mucomyst and DNase are the two primary ones. They're inhaled. They do have some side effects for nausea and vomiting. Expectorants is another category of drugs. They make more. They make thinner mucus, but they make more of that mucus. So because it's thinner, it's easier to remove. The other issue that we can have with secretions is that it creates a breeding ground for bacteria. So when we have accumulation of secretions, bacteria can proliferate in there, and we can get an infection. So here's an airway with a plug of mucus that is infected, and we would use antibiotics to fight infection. Now, when we're talking about COVID, it seems that the general presentation of COVID is a dry cough, not a cough that produces a lot of mucus. So in terms of COVID-specific issues, we wouldn't expect that these drugs would be a major player in what we're seeing, but because people with respiratory disease are more likely to have a bad outcome from COVID, they might be taking these drugs for their underlying respiratory disease. Another physiological process that we see in these diseases that we can control is bronchoconstriction. And just like mucus, if our airways are constricting, that's going to impede airflow. So we have a couple of strategies that we can use to manage bronchoconstriction, and they depend on there are different mechanisms that lead to bronchoconstriction. One mechanism is activation of the sympathetic nervous system. That leads to the release of norepinephrine. Norepinephrine binds to beta-2 receptors on the airways and activates those receptors, and that leads to bronchodilation. So in the center of the screen, we have our schematic of our normal airway, And then we have the activation of the sympathetic nervous system, release of norepinephrine, and bronchodilation. Conversely, we can have the parasympathetic nervous system activation. And parasympathetic nervous system activation leads to the release of acetylcholine. Acetylcholine will bind to cholinergic muscarinic receptors on the bronchioles, on the airways, and lead to bronchoconstriction. So we have this balance between sympathetically mediated bronchodilation and parasympathetically mediated bronchoconstriction. Another mechanism that can lead to bronchoconstriction is inflammation. And obviously inflammation is a big issue in a lot of the pulmonary diseases that we see, particularly in COVID, where we have an inflammatory process that can lead to hyperinflation and a lot of damage in the lungs due to that hyperinflation. So if we wanted to manage bronchoconstriction, we can take advantage of these different pathways and the drugs that we have that can control different aspects of these pathways. So the first strategy would be to regulate bronchomotor tone, and we can do that in two ways. Number one, we can use beta-adrenergic agonists. So these are going to be drugs that activate those beta-2 receptors in order to bronchodilate. So albuterol is the classic example of this. They're typically inhaled, but they can be oral. The side effects is nervousness, restlessness, and a tremor. They may cause cardiac irregularities in some people, particularly albuterol, but salmeterol seems to have less of some of these side effects. So that's one strategy, to activate the beta-2 receptors. The other strategy would be to block the cholinergic activity, so to block the PNS-mediated bronchoconstriction. So Atrovent and Spiriva are the two drugs that are probably the most common. They are inhaled. Dry mouth constipation, retention, urinary retention, and tachycardia are some of the side effects for that. We also have another category of drugs, methylxanthine or theophylline, and they're going to produce bronchodilation. There are several different kinds of drugs, several different specific drugs. There are some issues with toxicity with these drugs, can lead to confusion, nausea, and irritability, as well as some other ones. Here is a list of some beta-adrenergic bronchodilators, just for your knowledge. I was just going to leave this up in your slide so that you had a list. So those different drugs are going to manage bronchomotor tone. The other mechanism of inflammation, of bronchoconstriction, was inflammation. So we can manage bronchoconstriction by managing inflammation. And probably the biggest, the strongest arrow in our quiver for decreasing inflammation are glucocorticoids or corticosteroids. We have both inhaled and oral versions. We also have intravenous versions. They can be for long-term use, or they can be for kind of more shorter-term, quick-acting. A number of side effects that we are all familiar with, including osteoporosis, skin breakdown, and muscle wasting with long-term use. Glucocorticoids are used for a lot of different respiratory conditions. However, their use in acute respiratory distress syndrome is controversial and probably decreasing. In COVID-19, the worst outcome that we see, people who have very severe COVID-19 forms develop acute respiratory distress syndrome. Glucocorticoids are not recommended for the management of COVID-19. They may be used for other issues in people who are critically ill with COVID-19, but they are not recommended specifically for the use of for their anti-inflammatory effects to impact COVID-19. And basically the reasoning is because there's evidence of no limited effectiveness and possible harm with the use of glucocorticoids in people with acute respiratory distress syndrome. Another category of drugs that we use to decrease inflammation are leukotriene inhibitors. So Zyflo and Singulair are two inhaled versions of that. They may enhance the activity, the effects of glucocorticoids, so they're frequently used in combination, and they're generally well tolerated. Chromones are another category of drugs that prevent the release of inflammatory mediators. So nasal crom is probably the one that I'm most familiar with, and it can prevent a bronchospasm. It's not going to reverse a bronchospasm, but it can prevent a bronchospasm if it's taken before it happens. Here are some examples of corticosteroids. Again, just adding this so that it's in your handout so you have access to it. And here are some preparations where steroids are combined with longer-acting beta-2 bronchodilators in order to help to manage people with certain aspects of certain pulmonary diseases. Another pulmonary issue that we can help to manage is hypoxemia. And the major treatment for this is oxygen therapy. And oxygen therapy is going to improve arterial oxygenation by increasing the fraction of inspired oxygen. And ideally, we want that fraction of that the target, so the oxygen saturation, to be greater than 90%. Because once we reach that 90% point, the oxyhemoglobin dissociation curve, we reach a very steep portion of that curve. So very small changes in the percent saturation lead to very large changes in the oxygen content. Now, use of oxygen therapy can decrease dyspnea, and it can improve activity tolerance. There are some cautions to this. O2 toxicity, so prolonged exposure to high oxygen levels can lead to lung damage. And there are certain patients who are CO2 retainers. So prolonged use of high FiO2, high fraction of inspired oxygen, can decrease ventilatory drive, leading to hypoventilation. Both of these effects can be minimized by titrating the amount of oxygen using the lowest flow rate in order to maintain the desired SpO2. So those are risks, but for most of these patients, the use of oxygen outweighs the benefit of those risks, provided we're using it correctly. Now, other people have talked about the use of oxygen. This is a flow diagram from a clinical practice guideline published by Hillegas et al. For the use of supplemental oxygen. Generally, we want to maintain that oxygen saturation above 90%. If we start to see that it is dropping, we want to reassess. We might want to do some position changes, deep breathing, coughing, pursed lip breathing, and see how that affects the oxygen saturation. If those do not affect it, then we might start oxygen. Oxygen is treated as a drug, and we need a physician order in order to implement that. The best way to have the physician orders written, and generally the way they are in hospital environments, is to titrate the oxygen level to maintain a certain oxygen saturation. So rather than saying oxygen at 2 liters per minute or oxygen at 6 liters per minute, if we have the order written that way, where it's titrated to a certain SpO2, then we are free during physical therapy to adjust it in order to maintain that oxygen saturation level. But we do need that ability, so you just need to check with your facility and see what your orders are. Here are just a couple of references, pretty classic text in that clinical practice